The link between a healthy lifestyle and well-being, as well as that between health-related behaviors, the prevalence of NCDs and premature death have been widely established. The 4 types of non-communicable diseases, namely cardiovascular diseases, cancers, chronic respiratory diseases, and diabetes, that contribute the largest to morbidity and mortality due to NCDs, share between them the 4 behavioral risk factors of unhealthy diet, physical inactivity, tobacco use, and harmful use of alcohol. The prevalence of the behavioral and metabolic risk factors associated with NCDs in the world population is high, as figure 9 shows. The national NCD burden and risk factor prevalence closely follow global trends, as we can see in figures 10 and 11. The 2012 Global Annual Cancer Incidence Estimates showed that the 5 commonest cancers and 5 commonest cancer deaths in Nigeria were from the breast, cervix, liver, prostate, and bowel. Primary prevention of NCDs. The clinical and cost effectiveness of reducing risk factors have been well established. When individuals see the link between a healthy lifestyle and a healthy long life, they are willing to make sustainable changes to the way that they and their families live, given the support they need to overcome the barriers. Family physicians work with families for the prevention of diseases through risk reduction by altering behavior and/or disease agent exposure and by enhancing resistance to the effect of exposure to disease agents in primary disease prevention through brief intervention and vaccination. Brief intervention. In addition to intensive focused health education on the NCDs and their risk factors, the family physician employs the brief intervention strategy. This strategy is cost-effective in helping patients modify health risk behaviors, improve self-management of chronic conditions, and achieve improvements in health outcomes. This includes screening for smoking, unhealthy eating, excessive weight, harmful use of alcohol, physical inactivity, and high blood pressure as depicted in Table 1. Brief intervention using the Ask, Assess, Advise, Assist, and Arrange approach has been found to be an effective clinical strategy in many health conditions to facilitate healthy lifestyle changes. It takes advantage of the multiple visits of clients to the family physician to identify people with high-risk health-related behaviors and provide them support at their stages of change towards making lifestyle behavior changes for healthy eating, smoking cessation, cessation of harmful use of alcohol, weight management, and regular physical activity. Vaccine preventable cancers. Hepatitis B and C virus infections are the major causes of primary liver cancer. The human papillomavirus infection is responsible for up to 99% of cervical cancer. Potent vaccines are available for hepatitis B and human papillomavirus infections. Hepatitis B vaccination is now part of the routine primary childhood vaccinations. However, most adults and most girls are not vaccinated against hepatitis B and human papillomavirus infections, respectively. Effective mobilization for and the uptake of vaccination against these infections by eligible persons are the key strategies to liver and cervical cancer reduction. This service is one of the preventive activities in family medicine, taking advantage of the population-wide access to family medicine services. Early detection of NCDs. Early detection of NCDs reduces suffering, prevents complications, and improves prognosis, even with cancers, most of which are curable if detected early. Screening and enhanced access that facilitates help-seeking behavior constitute the key strategic tools for early detection of cervical, breast, bowel, prostate cancers, hypertension, diabetes, excessive weight, and abnormal cholesterol, as depicted in Table 2. Primary prevention of NCDs. Tertiary prevention of NCDs. Most patients with chronic diseases are managed in the front line of care. The initial and continuing care of patients, as well as the organization and coordination of all the health services they need, especially in chronic illness, is the trust of family medicine. The role of specialists in providing guidance in the management of complex or complicated chronic disease is well recognized and important for optimal care, but this should only be in the context of shared care, as most people with chronic diseases have more than one condition and need preventive care, often for unrelated conditions. The need for prolonged, continuing, ongoing care makes it necessary that the family physician remains the primary, central, and coordinating physician, as the patient is best served by a responsive, person-centered, effective system of care for enhanced health outcomes. Family medicine is thus the bridge between specialist care and population health. My stewardship. Mr. Vice Chancellor, sir, I here present my stewardship in 4 main areas. First, contribution to knowledge. Since joining the university, working collaboratively with my colleagues, I have intensified research in non-communicable diseases and the associated risk factors to provide the evidence and need for action. I present here the findings of research with my colleagues on the 4 major NCDs and the risk factors acting in concert as the drivers of the NCDs in our population. In 2011, we assessed the local prevalence of NCD risk factors in our family medicine clients at the Wesley Guild Hospital, Ile Ife. Our findings show that overweight and obesity, physical inactivity, high calorie and low fiber food intake were present in more than half of the subjects, as is seen in figure 14. In the context of a high prevalence of abdominal obesity, a major NCD risk, abnormal fasting blood sugar and high blood pressure were present in just less than half of the subjects. About 8% of the subjects were diabetic. Physical inactivity. The health benefits of physical activity have been firmly established. These benefits include prevention and management of many NCDs as shown in figure 15. 30 minutes of moderate intensity physical activity on 5 or more days of the week, or the equivalent, is the minimum public health physical activity recommendation to maintain and improve health. The evidence was based on the estimates of risk from leisure time physical activity measures from epidemiological studies. Physical activity below this level is termed insufficient and classified as physical inactivity. However, it is recognized that all forms of physical activity contribute to favorable health outcomes. Hence, total physical activity in all settings and domains of activity, comprising leisure or recreational, paid or unpaid work, and transportation activities accrue for health improvement. A higher than minimally sufficient physical activity has been shown to provide greater health benefits. A minimum total physical activity of 1 hour of normal activity of daily living and an additional 30 minutes to 1 hour of leisure time physical activity per day makes a healthy lifestyle amount of total physical activity, which is defined as health-enhancing physical activity. My studies on physical activity in collaboration with my colleagues have revealed a high prevalence of overall physical inactivity, especially among family medicine clients, and similarly, a high prevalence of inactivity in the leisure time physical activity domain among in-school adolescents, as shown in figure 16. At the International Institute of Tropical Agriculture, Ibadan, where the majority of respondents were field staff, 61.5% of management staff had sedentary jobs. A majority of this group did not engage in leisure time physical activity, thus constituting a physical inactivity at risk group, as shown in figure 17, due to lack of time and interest. Overweight and obesity. Formerly seen as problems of the affluent and middle-aged, overweight and obesity have now been recognized as global health threats for all age groups, even in developing countries. Like physical inactivity, epidemiological data have established excessive weight, especially central or android obesity, as a major predisposing factor for NCDs, particularly cardiovascular diseases, diabetes, cancer, and obstructive sleep apnea. In the African setting, the social desirability of overweight and obesity as evidence of good living and higher social status stands in the way of both the appreciation of its health hazards and prevention. In our study of the staff of our university and its teaching hospital, 30% of well-educated females, including health workers, were of the opinion that obesity confers respect. 21% reported that it is an evidence of good living, and about 50% were of the opinion that it enhances appearance. My collaborative research efforts in this area have shown that the prevalence of overweight and obesity among family medicine clients using the body mass index ranges between 27% and 41%, and 18% and 29% respectively, as shown in figure 18. This was highest among elderly diabetics and always higher for females than males. Intra-abdominal and abdominal subcutaneous fat distributions have been shown to result in higher morbidity than subcutaneous fat in the buttocks and lower extremities. In our studies, waist-hip ratio and index of abdominal fatness classified substantially more subjects as obese. The range was between 55.5% and 78%, compared with the BMI as shown in figure 19. A relatively high prevalence of overweight and obesity of 10.6% among in-school adolescents signals a serious warning as adolescent body build is likely to track into adulthood. High blood sugar. There is an increasing prevalence of high blood sugar worldwide as a result of urbanization, westernized diet, increasing prevalence of physical inactivity, increasing overweight and obesity, and the greatest increase is expected in developing countries like Nigeria. Our findings among family medicine clients at the Wesley Guild Hospital seem to support this as shown in figure 20. In addition, we have found that only a third of the subjects with high blood sugar were diagnosed prior to study in agreement with global estimates. High blood pressure. In 4 of the 6 studies between 1998 and 2013 that assessed blood pressure, the prevalence of high systolic and diastolic blood pressures was high. As expected, our findings showed higher prevalence of elevated systolic and diastolic pressures in practice-based compared with community-based assessments, as we can see in figure 21. Of concern is that elevated blood pressure was observed in about 3% of in-school adolescents. Tobacco and alcohol use. Tobacco use is the single greatest preventable cause of NCDs, and therefore a major risk factor for NCDs. About 6 million people die from tobacco use each year, both from direct tobacco use and secondhand smoke. Smoking is estimated to cause about 71% of lung cancer, 42% of chronic respiratory disease, and nearly 10% of cardiovascular diseases. It is also implicated in several other cancers, including oropharyngeal, breast, and skin cancers. Over 2 million people die each year from the harmful use of alcohol, accounting for about 3.8% of all deaths in the world, more than half of which occur from NCDs, including cancers, cardiovascular diseases, and liver cirrhosis. 7 separate studies in which we estimated alcohol use among our clients in the family medicine department found a use prevalence of 13 to 22%, while the harmful use of alcohol was found in 1 to 4% of our clients. Similarly, tobacco use at the time of study was found in 8 to 14% of the clients. Cancers. A large proportion of cancers are preventable through the adoption of healthy lifestyles, while a similarly large proportion of liver and cervical cancers are now vaccine preventable. However, most cancers are curable if detected early. Cervical cancer. Cervical cancer is the second leading malignancy affecting women worldwide. Its mortality is high, whereas it can be prevented, and 95% of patients with early cervical cancer can be cured. The screening of the majority of women at the risk of developing cervical cancer and the control of the disease effectively depend on the mobilization for an uptake of cervical cancer vaccination and screening by eligible women through family medicine. This intervention has reduced cervical cancer deaths in developed countries. Our study of female undergraduates in this university revealed that none was aware that sexual exposure to the human papillomavirus is responsible for 99% of cervical cancer. None had been vaccinated. Only 15% had been previously screened, despite the awareness of cervical cancer screening in 69% of the respondents. Helicobacter pylori. Helicobacter pylori, a gram-negative rod-like bacterium, and class 1 carcinogen, potentially treatable with antibiotics, with prospects for vaccine prevention, that colonizes the stomach is linked to gastric cancer and other malignancies of the bowel. My collaborative work with Nobel laureate Barry Marshall showed that the infection with the organism, which is by the fecal-oral route, tends to occur early in childhood. Colonization rate was as high as 60 to 91% in communities with poor hygiene. That diagnosis of active infection can easily be made non-invasively, even in children as young as 2 years of age, provided the child is able to blow through a straw, was established for the first time. In another study, we demonstrated for the first time, using a novel transport medium, that the organism retrieved with a string test in remote locations can be kept viable and transported to the laboratory for up to 29 hours transit time. In a local study, our team in Ife was able to determine the antibiotic sensitivity profile of Ife isolates to guide eradication treatment for the infection. My service, Mr. Vice Chancellor, sir. I joined the Department of Community Health when Dr. Emmanuel Abioye was the only medically qualified staff of the department. So I was given the opportunity to structure the delivery, supervision, and assessment of the undergraduate academic program in community health, which I first coordinated for 10 years. To the glory of God, I have been instrumental to the establishment of 2 key postgraduate professional training programs in Ife. First, the residency training in family medicine, and then the residency training in public health, which together have changed the human resources for health landscape and health development in Nigeria. I have been the pioneer coordinator of all the postgraduate programs in the Department of Community Health, starting with the residency training program in public health to the Master of Community Health, Master of Public Health, regular and part-time, and recently, MPhil and PhD. Mr. Vice Chancellor, sir, my major contribution to human resources for health development in Nigeria is the commencement of teaching in family medicine, second only to the University of Calabar, and health management at both undergraduate and postgraduate levels, not just within the department, but across departments in our college. These 2 disciplines of medicine shape health services delivery and development worldwide. I am delighted to observe that the revised undergraduate curriculum has dedicated portions for both family medicine and health management. Of note is the fact that I have built the capacity of many practitioners in the national health workforce today in both public health and family medicine fields. In family medicine alone, I have impacted a few hundreds of family physicians in the Nigerian health field. In conclusion, Mr. Vice Chancellor, sir, I have presented the burden of non-communicable diseases globally and nationally, as well as the evidence from our collaborative work in the area, showing that NCDs and associated risks are not the problem of only the affluent and later life. Most NCDs and NCD-related premature deaths are largely preventable, and the means to prevent and control NCDs are not only available, they are feasible and cost-effective. The evidence base for action continues to grow. Actions to prevent and control NCDs should occur over the entire life course at multiple stages of life. I have also presented the role of family medicine in the control of the epidemic. Only a combination of population-wide, family-focused, and individual interventions using cost-effective initiatives that strengthen the overall health system is capable of arresting and reversing the trend to reduce NCD burden, improve population health outcomes, curtail health expenditure, and promote socioeconomic development. However, national awakening to recognize the need for action, mount a commensurate national response, strengthening the national health system for appropriate response is overdue. The time to recognize NCD as a national priority and take timely action is now. Nationally determined sets of the needed basic health services and essential, safe, affordable, effective, and quality medicines must be made available to all through universal health coverage. As part of the family-focused and individual interventions for NCD prevention and control, families and individuals must take responsibility for their health, adopt healthy lifestyles, and make optimal use of preventive services as depicted in tables 3, and 4. My future plans. The prevention and control of NCDs is a growing field. Updating the evidence for trends in prevalence and the associated health behaviors, developing interventional strategies and implementation research will be top on my research agenda. With the changing structure of modern society, especially the disintegration of the extended family structure and the strong economic strain on nuclear families, the changing patterns of social integration, the relational context of social relationships, and the changing role patterns of the family in healthcare constitute an active research area of interest of mine.